Gentlemen, thank you. Indeed, do we still need a randomized prospective trial comparing VATS to open lobectomy? That's the question. We all know that there is an extensive amount of literature showing safety, feasibility of VATS lobectomy, also showing superiority over open lobectomy, and several dedicated centers around the world have incorporated adapted the procedure as a standard of care for early stage non-small lung cancer. And referring to the keynote lecture of yesterday by Mr. MacDonald, I think it's an excellent example of a disruptive innovation. So you might question why I bother you with this evidence-based medicine when we can leave it over to the market. And that's exactly the question, why shouldn't we leave it over to the market? Because with a disruptive innovation, you're disrupting an existing market, that's happening, but eventually it should replace an earlier technology. And that's the problem, because we are unable to dominate the market at the moment. And this is shown in the next slide. If you look at the different databases, for example, NIS database still has an open lobectomy percentage in 2011 of 60%. The STS database, mainly large centers report to this database, so the percentage may even be lower, shows in VATS lobectomy percentage over open of 44%. And in Great Britain and Ireland, there are much lower percentages reported. In the Netherlands, we also have a mixed practice. There's a range between 0 and 85%, depending on the center of implementation of VATS lobectomy. Overall, around 40%. And I think Denmark is an excellent example of concentration of long surgical care. Adaption of VATS lobectomy, they have a percentage which is higher than 60. It's probably the only country in the Western world. So, to go back, this is an important problem that we cannot dominate the market, and there might be place for randomized trials to adapt guidelines, and with implementation of guidelines that advise VATS lobectomy as a standard of care, we could change this random and mixed practice. The second problem, why there should be a moment of reflection in this disruptive market, is the nodal upstaging problem, that you see in the open lobectomy group a higher percentage of nodal upstaging. And there's excellent work from the US. Here I have an example from Denmark, Peter Licht, who shows, and this is in the next slide, a nodal upstaging both in N1 and N2 nodes, which is higher in the thoracotomy group. So this should be clarified. So altogether, current practice is random and mixed. There is no standard of care and evidence-based guidelines, and there are oncologic concerns. So the objective of this study was to investigate the need for a randomized trial for the above reasons. And we do that by evaluating the quality of the available evidence, comparing VATS to open lobectomy. How did we do this? We did a systematic search of electronic databases. We only included studies that compared VATS to open lobectomy with inclusion criteria of stage 1 and 2A, studies larger than 10 patients, and different endpoints were included. All studies were abstracted by 2 independent reviewers, and data on quality of the studies were extracted, like design, characteristics, case matching, and the intention to treat, follow-up, whether a historical control group was used, the number of studied patients, the country, continent, etc. And we used, for quality assessment of the non-randomized trials, we used the Newcastle-Ottawa scale. It's a NOS scale. It's one of the used scales to look at the quality of available retrospective studies. So the results. In total, 880 citations were screened, and after exclusion of non-relevant studies, as you can see, finally we included 50 studies, from which 3 randomized controlled trials and 47 non-randomized trials. If we look at the results of the randomized controlled trials, 2 out of 3 were older than 10 years. Number of patients were low, between 30 and 50 patients per arm. All studies, none of the studies performed a power analysis for primary endpoint calculation, and there was no intention to treat in those 3 studies. The 47 observational studies were scored with the NOS score. This score ranges from 0 to 9, and as you can see here, the mean score of these 47 studies was 6.2, and most studies, as here in the middle, had an intermediate NOS score, few high score, and 4 studies a low NOS score. If you look into detail of this, into these parameters, I show you here that 30 out of 47 studies were retrospective without case matching. 10 out of 47 studies reported conversion to thoracotomy, that's only 20%. 18% reported on lymph node dissection. Quality of life is rarely studied, and in 3 studies, a historical control group was reported really in text. That means an older open lobectomy group was compared to a younger VATS lobectomy group, and we expect that 18 out of 47 studies may have used an historical control group because the database was spread over more than 6 years. Here I display the increase in number of studies over the years. In yellow you see the retrospective cohort studies. Of all the 50 studies included in the study, you see an increase in number of reported studies. And the RCTs in red, you see that in the beginning of the era of VATS lobectomy, 2 randomized controlled trials were performed, as I showed before, and 1 recently. So in conclusion, overall level of available evidence comparing VATS to open lobectomy is low. It's mainly based on retrospective cohort studies with an intermediate NOS score. There are concerns with regard to completeness of resection, as I told in the introduction, and outcome parameters are not answered yet. And therefore, we believe that multi-center and multinational RCTs, both addressing functional and oncological outcome, are needed. And in this disruptive innovation, there should be a moment of reflection to change this random and mixed practice. To change the Dutch situation, we started a randomized trial. It's called the SCOPE trial. You can find the details on clinicaltrial.gov. It's a multidisciplinary approach, of course, and many people are involved. At the moment, we have 3 hospitals, including patients in the randomized arm. And we hope to finalize inclusion within 1 to 2 years. And we will keep you up to date about the results. Thank you.
Well, thank you very much. To start the discussion with a question of mine, where would you see the difference between Denmark and Great Britain? What is the difference between, is that another attitude as to scientific background necessary or not? Or is that very talented surgeons in Denmark? What is this is close together, very different picture.
It's difficult for me to answer. Probably someone from Denmark is in the audience. But I think Denmark made a decision also by government guided to concentrate cardiac and thoracic care into, I think, 4 or 5 centers. And those dedicated centers, as you see also here in this meeting, dedicated centers, they adopt new technologies probably earlier or faster than smaller centers that keep the way they are doing it for years into the practice. So probably the concentration of care and formation of dedicated centers is really helping to introduce VATS as a standard of care.
So I'm interested in the SCOPE trial that you mentioned, and a couple of issues was, I think once surgeons start doing VATS and adopt it, it's very hard to change that. So you're going to have a group of very experienced people in the study who now do VATS. So how do you deal with the surgeons buying into the trial and saying that they're willing to randomize their patients? And on the other hand, I'm also interested in how many patients you've actually enrolled, because we were involved in a trial comparing SBRT to surgery, and you have 2 very disparate therapies one invasive, one non-invasive, and you have to kind of sell that to the patient. And I wonder what strategies you're using to discuss that with your patients, and again, what your success rate so far is since the trial's been open.
Yeah, okay, thank you. Regarding your first question, the surgeons, it's difficult to include centers in the study and convince surgeons to participate, because if they perform VATS most of the time, they use it as to expose their center as minimally invasive center. So they choose not to do the open. On the other hand, we have found several centers in the Netherlands where VATS lobectomy is a standard. They have their learning curve. They went through their learning curve, and they still also perform open, because you have a certain case mix, of course, that you need this expertise. And they actually do participate in the study. But most centers did not want to participate because of the reason before. Inclusion of patients, regarding your second question, what is really helping us is that patients want to get rid of their cancer. That's the first thing they want. And they want to get rid of the cancer and the lymph nodes. And the way it's performed is the second discussion. And if you really explain the advantages, disadvantages of both procedures, as we do in the protocol, including the questions with regard to nodal upstaging, most patients really seriously think about joining the trial. We find that about 50% of patients, 50 to 60% of patients really read the information and join the trial. The other 40%, they refuse. And they are followed in a prospective cohort.
Time. Next question,
Okay.
please. Short two questions.
All right, quick question. So again, I appreciate what you're doing. A question is, if you look at the syntax trial, which proved coronary bypass is better, has it really changed what our customers really want, which is generally less invasion in their body? And so when you design this study, what is the endpoint that's going to show that are you trying to prove equivalency? And what is the percentage that you, with the background that you're trying to when you complete the study, show that they are equivalent? And then the other question is, do you have correlative studies within it? Because I think that the big problem we have is not so much comparing one versus the other, it's the mechanism. Why is VATS better? There's not that's really the mechanistic, is really the scientific question here. Mm-hmm. And do you have correlative studies built into your trial to actually show what is the mechanism by which one might be better than the other? Thank you.
Okay. We don't have mechanistic parameters in our study. That's really would be very interesting, like inflammatory response, but the primary endpoint is it's calculated on quality of life and on length of stay. And as secondary endpoints, we have oncologic endpoints. There's a lot to say about his choice, but we have about 200 patients in the study, 100 in each arm. And we have, as I said, primary endpoints, length of stay and quality of life.
Well, when you did your hypothesis planning, what is the percentage that you're going to show? What's the statistical that you're going to take to show that they're equivalent?
For length of stay, it's 2 days.
So it's within 2 days, they're equivalent.
So the difference is 7 versus 5 days length of stay. And in quality of life, it's difficult to get calculation because there's a sub-calculation of functional outcome.
It's very interesting discussion, but we have to move on a little bit. Last question,
I'm
please.
going to shorten it by not asking a question. I think you're right. The UK has a mindset which is quite different, and which is why the VATS procedures are lower. And it may be due to the mixed cardiothoracic and cardiothoracic training that produces that. I mean, I've been doing minimally invasive lung surgery, lobectomies for 15 years, but my colleagues still look at me and says, "Why don't you make a decent incision?"
That's a good point.
Thank you.
Thank you very much.